I'm Sibley. I'm a neo-med grad from 2018. I've always wanted to work in a health center, and HRSA, which fund the health center, also pay for my neo-med tuition and also gave me your stipend. And I just finished with my residency at University Hospital in Cleveland, and now I'm in ICHC, which is International Community Health Center, is at 370 East Market Street, right across from SUMA. If anybody would like a tour for our health center, I'd love to see you there. This case is from a nurse practitioner. Her name is Jamie. I have not met this patient, and Jamie is not her PCP, and we feel like there is a lot more we can do for this wonderful lady. She is a 68-year-old female. She was from Afghanistan. She got here about 2017. She first settled in California, and then and then now she's in Ohio, in Akron. She only speaks Pashto. For her living situation, she lives with her son and 8 grandchildren that I know of. Some of the social work says her daughter is the primary caretaker, but most of the time when he comes to visit, it seems like her grandson is with her. Her current diagnosis, the column on the left are all the chronic diseases that we are not able to address. Uncontrolled hypertension, COPD, PVD, or a arterial insufficiency. Her entire left iliac artery is blocked. Thoracic aortic aneurysm. She has GERD with H. pylori infection, and major depressive disorder, grief, PTSD. I believe her son died in the war before they arrived here. She has insomnia, she has hearing loss, and she has low back pain. But if you will look at it, it's just arthritis, and then bilateral spondylolisthesis. It's just this disc slip a little. I don't think not even bad enough to have neuropathy. And then other additional diagnoses like osteoporosis, seasonal allergies, multiple falls, varicose veins, appetite loss, lymphedema, and then I put carotid endarterectomy. That's her history, because in her medication list, there is aspirin. And then if you go down some of the specialist visits are the ones that she has only visit once and never follow up. And for her medication, she is on 4 antihypertensives. She is on amlodipine 10 daily, losartan 100, metoprolol succinate 75 milligram daily, and spironolactone. And psych meds, she is on Zoloft, Remeron, and then she takes hydroxyzine 25 for sleep. And other medicine, she is on Tylenol 500 2 times, or 2 tablets. That's actually kill 8 hours as needed. And then alendronate, Fosamax, aspirin, because she has for secondary prevention, and atorvastatin or Lipitor, and vitamin D3. Flaxerol 5 milligrams 3 times a day as needed, and then other stuff, lidocaine patch, Maalox, and eye drops. Her functional status, she actually doesn't have any major disability, but she is wheelchair bound. The OT assessment in June from SUMA, it says she has impaired mobility and ADLs, full tolerance of ambulation. And when she do the assessment, she presents with impairment of coordination, processing, strength, body mechanics, motor planning, activity tolerance, transfers, and then ADLs and IADLs. OT recommend skilled occupational therapy, but patient declined, and she asked her grandson to tell the therapy in Pashto through the interpreter that I can't do anything. And so physical impairment is the same thing. They said she has baseline left side weakness and numbness, and last time she was in the emergency room, they said she needs full assist to transfer from wheelchair to bed. For her low back pain, when she saw sports medicine, she declined PT also. Mental impairment, there's no deficiency noted, but like a lot of patients, she demonstrates poor understanding of plan of care and treatment. Hospitalization, she has 2 in the past 2 years. One time was hypertensive urgency, and she was in hospital for a couple of days. And April last year, she was in the hospital for 5 days for abdominal pain and cholelithiasis, so gallstones. That's not enough to require treatment, and biliary sludge. The doctors at that time says it's more like there is a big element of somatic symptoms disorder, mostly from PTSD that they can think of. And a whole bunch of ED visits. This year, she had a mechanical fall and she has a thigh abscess. Last year, she also had a mechanical fall. And then earlier last year, she has chest pain and cough. And then in 2020, cough, dehydration, and neck pain. My primary issues of concern, I think the biggest thing is we have so far the mid-level practitioner is taking care of her, and he is doing an excellent job with preventative health, but the chronic condition management, there is a little struggle. For the past 3 years, we mostly try to take care of her high blood pressure. And then like for the coordination of care, when you look at number 7, like she has a whole bunch of specialists. Either she has seen and lost to follow up, or she has yet to be seen that has some important conditions that we have to take care of. So for this, I was hoping there is some attendings in the audience, so you can let me know like how do you manage your residents or your mid-level practitioners to help take care of our patients with all these complicated conditions. And then the second thing, behavioral health, she actually, like, just because she has so many things that we have to take care of, nobody has addressed her anxiety, depression, and PTSD. Her medicine, the Zoloft, the Remeron, and the Atarax, that was added when she was inpatient, and that when the psych team was following her, and there was no outpatient follow-up. And the biggest thing is the apathy. Her I know she has 4 antihypertensives. I'm pretty sure she's not taking it. She's honest about not taking the antibiotics or triple therapy for the H. pylori infection. When she does when she had the hearing loss and she went to the doctor, the ENT, she couldn't she either couldn't or doesn't want to follow the instruction for the hearing test, so it was inconclusive. And again, she doesn't want to participate in PT. She doesn't want to participate in OT. And reaching out to patients, so our nurses, our doctors, specialists, nurses, specialist doctors, and if we all have a hard time trying to get a hold of her on the phone. When she was in the hospital, when she was hospitalized, in that 5 days, the social worker actually tried several times to get a hold of her family, but that didn't work. And by social worker, I mean the case manager. And we do try to have social worker to help her, but I think medically she is very complicated, and socially she's also very complicated. So instead of being able to address what she needs, we're like helping her with missing medications, like missing DME and missing medical supplies. The social work nook says they called the supplier or the pharmacist and the medicine was delivered. And when we called the patient says they never received it, which is pretty common for my other patients too. And then, of course, the chronic condition management, the high blood pressure, she cannot take the HCTC because she ended up in the hospital with electrolyte imbalance. She can't go up on her Topro, and she's already maxed out on her amlodipine on Norvase, losartan, and cothyladone. And in addition to all the extra conditions she has, it's kind of hard to try to decide the conditions that can cause secondary hypertension. And COPD, just like all our other patients, we have to teach her how to use the inhaler many, many times. And the last thing, the frequent ED visits, I think is a combination of our struggles and her struggle. All the conditions that she went to see the emergency room for are not the best way to utilize the emergency medicine. But I think a lot of times we are so worried about her blood pressure or any other things that we don't really listen to her. Like the thing she worry about is her cough. But I think for like 6 months it wasn't addressed and she keep going back to emergency room for that. So that is the case. I hope if anybody has any questions or need clarification, please let me know.
Would somebody like to start? Sue?
Well, yeah, I can. I mean, it sounds like medication adherence is a big issue. And you said even with the delivery of her meds that that she didn't receive the delivery. So one thing that I do know about when you don't receive deliveries is that the pharmacy will, at least most of the pharmacies that I've worked with that they will send it out again. Have they done that for her, that if she calls and says that she didn't get it? I don't know if she can communicate, if there's somebody in.
She's like a lot of our patients. When they don't get the medicine or when they decide to stop the medicine with side effects, they don't let us know. I can tell you, we next time, if I can say next time, I won't. So we use Klein's so she can get the blister pack, and it's a lot of work just to keep track of what to go in the blister pack. And we even have nurses that they can come and will help pack the medicine again from the bottle to the blister pack. That doesn't really help her. And
okay, so I think that it's really hard because you're trying to control her blood pressure, but she's probably not taking her medication. So so that gets so tricky I don't know if there's and to me, I'm not sure, but it sounds like that's one of her biggest issues, is that her blood pressure is uncontrolled. So I don't know how you would feel about this, but maybe having a visit that's kind of dedicated to education about that, trying to simplify her regimen. If we could do less medications. Does her blood pressure run very high all of the time, or do you see it go up and down?
I didn't mention. So the NPs that take care of her, like we have a blood pressure cuff for her at home, but of course, like she's not going to keep track of it. When she comes in, it's usually 150/90, and then every time she ends up in the emergency room is like 200, 115. And also she told Jamie, the MP, that like when her blood pressure is high, she will take twice as much of the blood pressure medicine, because that's what she thinks she needs to do.
Okay, yeah, that's kind of scary. You're right.
Very.
And her kidney function is okay, or she has issues with her kidney function probably?
Yeah, this is the thing. Everything, she is perfectly fine. Like X-ray is fine, CT is fine, kidney function, liver functions perfect, no anemia, nothing. She just apathy.
So I guess there's, in my mind, there's two things that come up that I would think about to do this, and they're time consuming to do. So I'm not sure that this is possible, but like I said, have that appointment that's focused on how important it is to take her medications, and then have, I don't know if you have an MA, or if somebody in the office can call her and say that we're going to focus on this blood pressure. I want you to make sure you take these medications, and then we're going to call you and you can check your blood pressure. I sometimes, if they don't have them written down, I just ask them to check it while I'm on the phone, and see what it is, and ask them right then and there, well, over the last few days, how time did you miss your doses at all? And just try to do kind of some motivational interviewing as well, as far as, trying to get them to understand. And I know there's a language barrier, so that probably makes it even harder to do that. But that we want you to really try to focus on that. Now, there's other things that might help that too, like her depression. Like right now you have her on sertraline and mirtazapine. So I'm not sure how well those are working. Would you say those are working, Sibley?
She has never followed up with the psychiatrist. So, and I agree with you. The Zoloft and the Remeron together doesn't work. And then she's taking hydroxyzine for insomnia, but she's taking Zoloft, which can cause insomnia. We haven't been able to coordinate. So it's a lot of little things. We haven't been able to coordinate care. She has not seen a psychiatrist, which she needs.
Okay. So I would say with this mirtazapine and the sertraline is I'd want to make sure that the mirtazapine is being given in the morning, not at night, because at that dose in an older person, it might cause the insomnia. And the sertraline too, hopefully would be given in the morning. So trying to get her, the sertraline dose is fairly low, so she's not responding. We could increase that dose. And then starting to evaluate if we need to go to a different regimen. It sounds like you've already sent her to psych, but she doesn't really want to go to psych.
Actually, that wasn't like, it's because there are so many things that wasn't even on the list.
Yes, they all kind of correlate together. If her pain's not controlled, that might be contributing to her hypertension. So I see a lot of pain medication on here. So she is, and the other thing with her hypertension, I guess, is that, could we add a PRN medication for her that would help with her blood pressure so she doesn't double up on dosing? Give her a way to handle when she checks her blood pressure and it's high. That might be.
We tried the clonidine and failed.
Okay. Boy, you bring us the hardest patients, I'll tell you. So I guess with the blood pressure, like I said, just to kind of tie it up, it sounds like you've already done a lot. So I don't know that I have a lot of suggestions with the blood pressure. Dr. Drost, can you think of anything else that we may be able to help her with?
As far as the medications themselves, no, I guess not really. I think maybe, and again, it's back with that motivational kind of interviewing and providing the tools maybe to keep track of them and like charting, like, and have them check off when the medications are being given. Does she have, is her son, daughter, one of the grandchildren, is anybody helping her with her medications?
So from what I read in the notes and from what Jamie knows, they are trying to help, but she's not that old and she's very stubborn. So she is the one who doesn't want to work with them and
Yes.
like not helping them to help her.
You know, it just
Yeah.
seems like she's a person who likes control. So, you know, anything that we can give her to allow her to be the one that's kind of driving it. So, you know, I'm trying to think what we could do for her, because I don't think this is that I'd be worried about increasing her blood pressure meds, because if she's not adherent, then we might end up too low if she becomes adherent.
Well, I do think, like, sorry, I think that, you know, even backing up and you're kind of, I think, right in that on that target, Sue, of like giving her control. So what is her main concern? And let's focus on that. And this goes, I think, to kind of your question about like guiding or you know, residents or APPs that you're working with in these complex cases too. It's really setting the priorities. So like, what is the biggest concern? And let's focus on this. And yes, there's lots of overlap and everything else, but if you come at this with this problem list and this plan of like 14 different things, everybody's going to get super overwhelmed, probably including me, right? But really prioritizing it, but that has to be really aligned with exactly, Tracy just put in there, like what the patient's main goal is. And so really, you know, sitting down to build that rapport. I worry too that probably because of her background and language barriers and all of this, like she's really not also trusting the system, trusting the process of healthcare here. And so taking that extra time to sit down, build that rapport, identify the patient priorities, and how do we align her priorities through like a motivational interviewing type of thing to like the certainly life-threatening medical conditions that she has. I mean, I think obviously the blood pressure and with her vascular disease becomes a super concern from the health standpoint.
And you're right.
But I also wonder how that overlaps with the mental health stuff.
Yeah, and you're right. The vascular problem is already a big concern because she already had the carotid endarterectomy, and she had the PAD, and she also had a thoracic aortic aneurysm that is not addressed. So the vascular health is important. And back to motivation interviewing and the chat from Mr. and Mrs. Lauer or Dr. Lauer. I am the only one who likes doing motivational interviewing in my clinic, and I think the mid-level that we have, the training is more task oriented. And my question was like, if I was to take care of her because nobody else would be happy to do it, then I'll end up taking care of every single complicated patients in my clinic. And I know attendings don't do that, but I don't know how, like, I don't know how to like delegate these tasks to other mid-level, or I don't have any residents. So I don't know what to do.
Yeah, well, I mean, I think it's actually like nursing. I don't know, my experience, nursing and our APPs are actually much more skilled than a lot of physicians in the education, in the teach back, in you know, maybe not motivational interviewing them that specifically, but in those like foundational principles into you know, motivational interviewing. So maybe that's an educational opportunity at the center in general.
Yeah, I agree with Dr. Drost too, is that and Tracy, and that's a great idea, is that it seems like maybe work on one thing at the time, and the first thing you're going to work on is what matters most to her. So just, and it's probably not going to be hypertension that matters most. It's probably going to be pain, or I can't sleep, or something like that. But if you kind of have frequent visits with her and tackle one at a time, and then as you make some progress for that, then she'll start to trust you and maybe be willing to also take care of some of the other things that we know are more of a concern, but they're probably, hypertension is not something that necessarily makes people feel horrible. Sometimes it does when it gets real high, but and I'd also wonder if she's having side effects, or if she's perceiving she's having side effects for any of these medications. So like a lot of times patients won't, they're going to go do something, so they won't take their diuretics. That's really, really common. So asking her at her appointment, what side effects are you having from your medication, so that you can come up with some others to have. Her cognition, she's like in her 60s. So, but she's on a couple of medications that usually cause people some issues with falls and with cognition, and that is the cyclobenzaprine. And then she's also on hydroxyzine that she's using for sleep. So I would work to get those medications off her list. Again, I think it would be best to see what is bothering her most, and maybe not do this immediately, although she's had falls, so I would be pretty high on my list. But finding out how much the cyclobenzaprine is helping her with her back pain. Right now she's on Tylenol, she's on a Lido patch, and she's on cyclobenzaprine. So asking specifically which of those actually help her. What would come to mind that she might be able to use that would help her with anxiety and with pain would be, I prefer pregabalin if there's a way for her. It's a generic now, so it's much more affordable than it used to be. Or gabapentin would be two drugs that I would think might help to replace the cyclobenzaprine for her. And then for the hydroxyzine, that if she's probably taking it, it sounds like she's using it as a sleeper because of the anticholinergic effects. Prefer to use something different. We could try melatonin at first, because older patients have a deficiency in their melatonin. I would start with at least 3 milligrams. And then better to do the Nature Made. It's not that much more expensive, but it goes through the USP process. And then for the and if that doesn't work, then trazodone would be another alternative that would start. The dose would be 25 milligrams to help with her sleep instead. So those are, and then making sure she's not taking the mirtazapine at night.
With the trazodone?
What's that?
Not taking the Remeron you mean with the trazodone, or just lean the Remeron?
Oh, I would say I'd leave the Remeron and the sertraline on for now, but my first step would be to get rid of those anticholinergics. The big thing about mirtazapine, though, if you get above 15 milligrams in older patients, oftentimes that causes insomnia. So I would try moving the mirtazapine to the morning, right along with the sertraline, rather than, and making sure she's not taking sertraline at night too. Some people, if you're not specific, they might do that. So just making sure that the drugs that can cause insomnia are moved to the morning.
So we have a couple things in the chat. Carol wondered about the age of the grandchildren, if you're able to contact them. And she had home visit ? And Tracy's typing in some things about interpreters and using them with medical appointments and assisting in the education motivational interviewing. Another one from Tracy, need to address the language barrier. And hearing loss to ensure effective communication to be able to build trust and rapport. And then Michelle wondered if the clinic has any capability to offer home-based care services, home nurse or physician. I just add on to that, have they been in contact with the Area Agency on Aging at all?
No, well, maybe with the Area Agency on Aging, but for Michelle, ICHC doesn't have home nursing or home physician visit yet. I'm hoping I can get some help from a CMIT with that. And for Tracy, I mentioned in the presentation too, so we did try to address her hearing loss, and she just wouldn't call. I made it sound mean. She is not willing to participate with the hearing test, so the ENT couldn't assess her hearing and give her any help at all. And from the ENT notes, it says that the interpreter explained the process before, and throughout the hearing test, they tried to redirect her, and she just wouldn't do it. But I know she can follow instruction because for her PFT, she did beautifully. Like she followed all the instructions, the result came back fine. And for Carol, again, like I don't know how old these 8 grandchildren are, but we talked about control, and I think the grandchildren are on the passive side. Like she usually just make them tell us that she can't do anything.
Just a note of like encouragement and positive, right? Like these cases are really challenging. And she kind of brings to mind a house call patient of ours. I don't know how many hours Sue has spent on the phone with her, talking about her blood pressure medicines, talking about the potential side effects. Like, but it's been, I don't know, a year, 18 months, maybe longer. I lose total track of time. And I think we're at a place where, I mean, she still Canada is what she wants sometimes, but more often than not, she'll reach out, she'll, express her concerns, and has made good strides in both, her blood pressure and her diabetes control. So it can take a while to build that rapport, to build that trust. But it is possible. And from the like frustration kind of side, or that like panic side, like, right, like that's what we do. We want to fix the problem. The problem is the blood pressure, and quote, right, like that just that feeling of, if you just take your medicines the way you're supposed to, it would be fine. And then also admittedly, sometimes it's that, well, what's everybody going to think if she's coming in with ED, right? I'm not doing my job. But you are, and these are people who have their own approach and thoughts on things, and building that rapport is probably one of the healthiest things in general that we can do. So definitely worth the time.
Yeah. I know, like, just from reading the notes, I know she wants to take care of the cough. And again, the thing, I'm not her PCP, and Jamie, who is like me, is not her PCP either. Her PCP is awesome. He's task-oriented, and I wish I was like him. Because he was in the clinic, all our screening percentage is like way above national average. If we're going to talk about colonoscopy and cervical cancer screening or blood pressure control, our numbers would make a lot of attendings blush. So like, but if I tell her PCP that I can go ahead and take care of this patient, then I'm going to be going ahead and taking care of a lot of these patients, and I don't feel like I am that great of a PCP yet. So, and that's the thing.
Let's also remember that's why we work as a team. So, working with Jamie, exploring what motivational interviewing looks like, and maybe that's the way to kind of work within the team structure, and going forward too.
I know I don't know if they'd be willing, but I know Ricky, who is a part of our GWEB team, she gave a great presentation. She came to and gave, I don't know if you guys have noon conference or if there's any time to actually have somebody come in and give a half-hour talk about just how to do motivational interviewing. Because if, you know, it's a process that's I did not grow up with it, so it takes some practice to do, and it was very helpful to hear somebody doing it, you know, how it works.
I was thinking about that too, Sue. I was wondering if we couldn't get Ricky engaged to do through one of our educational venues to actually redo that for us.
Yeah, and maybe like she could do an echo
Yeah.
for it, and then people could be invited, and it's recorded, so that could then be something somebody could watch on their own time, or if there's no time in the clinic, just thinking of ways that it could be delivered. But I think, you know, it was a very helpful interview to me, so I would imagine other people would find it helpful too.
I'm going to suggest one more thing, Sibley, is the Habitat program for her. I don't know if she lives in the target area, but if she lives in one of those neighborhoods, I think you already, for your last person that you brought forward, I don't know if you were able to contact them, but she might be qualified for that that Habitat program where they'll do the fall prevention stuff. So she might benefit from that.
Yes, and that was very helpful from the last presentation. I'm sending a couple referral for the Habitat for Humanity, and then I'm starting on one referral for the home palliative care, and I'm weaning 3 people off of the amitriptyline because
Good.
it bugs me.
Great.
That's wonderful to hear. That's great, Sibley.
Yeah, but if anybody can make a suggestion for home visiting doctors and home visiting nurse, that would be helpful. And then psychiatry, like psychiatry that can do the culturally and linguistically appropriate care with the PTSD and war trauma. That would be helpful for me too.
Did she get a hold of the area agency?
Sorry, did she?
Or should she?
For the
I mean, they'll do an assessment and find out whether she's eligible for any type of. Michelle or Tracy, did you have that number, the resource number?
Yeah,
maybe everybody left.
I'll drop it in the chat.
As far as, yeah, I think psychiatry is going to be a challenge. And through, I mean, culturally, linguistically, I think, you know, folks and resources through aging are probably going to know a lot more than I am, but I do know SUMA has a Center of Excellence or something along the lines for a PTSD, traumatic stress program. So certainly worth reaching out and seeing, you know, if they have resources.
Yes, we have a psychiatrist. He is only there once a week. And then we have a psychologist that's there twice a week. But the psychiatrist, I already feel that it is not a good match because he likes exposure therapy. Or is it called exposure therapy? I don't think exposure therapy is going to work with this 60-some-year-old lady. Like, it's the personality difference.
So Tracy's put that number. Can you see that, Sibley? The number for the resource center to call in there.
Yeah, don't use the first number, use the second number. Sorry.
Oh, didn't see that.
I'll send you the chat, Sibley, when we're done.
Cool. And then maybe afterwards you can let me know like what they can do for her that I'm not familiar with.
So the Area Agency on Aging, we help facilitate services for individuals in their home. So things, you know, like aid services, meals, transportation, home modification, chore services, We promote people to stay in their homes who otherwise might have to go to a nursing facility. You know, it's like Medicaid waiver services. We also have services for individuals who aren't Medicaid eligible. We also have health and wellness services, educational services, Tai Chi, all kinds of different options. So that second phone number I put in there, or if you just go to our website, lists all of our services. And we have nurses that will come out and do a free assessment and go over all the offerings and see what the needs of the individual is and see where we can help.
And I think you said in the past presentation, it's in Summit County is 65 and over.
We do a wide variety of ages. Most of our individuals are 60 or over. Our agency covers Stark, Summit, Portage, and Wayne County, but there is an area agency on aging in every county in the state and nationwide. So anywhere you go, there is an area agency on aging that can assist older individuals to stay at home.
Oh, nice.
And just to add, and certainly I think you said that she was from Afghanistan, but our area agency does quite a lot of work with the Nepali population in Akron. And so, you know, and I think have done like additional education, et cetera, on kind of that cross-cultural care considerations as well. So I'm assuming pretty comfortable also with working with translators and all of that. So that's not something that's, you know, foreign word to the agency.
No pun intended.
Right. We're very comfortable using interpreters in person, over the phone, virtual. We do that a lot.
Awesome.
All right. Well, unless Sue, did you have something else you want to add?
I had just one, thanks for picking up on that. I just had one more med thing, is that she's on alendronate 10 daily, and that might be one thing we can help with her adherence, is just to make that a once a week dosing. I don't think the price on it is that much different. Just that taking the 70 milligrams once a week would be better for her than the 10 daily.
Got it.
All right. Well, thank you everybody for the great participation, the great suggestions. And Sibley, I think we will follow up on this idea about getting something together on motivational interviewing. I think that's a need that you've pointed out. So hopefully we can get something on the books for that.
Yeah, and I'm really into motivational interviewing, and I think I didn't realize that a lot of people may need some convincing.
Yeah.
Like why it's important. And I just take it for granted that everybody should be doing it. So,
Yeah.
yeah.
That finding out what matters to them is like, it's more important than you think. So that's great.
Right? Yeah. So
All right. Well, thank you everyone for being with us today and for participating. So thank you.
Have a good day, everybody.